Talking about treatment, so now that we have spoken about what this is, there are two currently available treatments for both adult and pediatric patients. One of them is the Larotrectinib, and the second one is the Entrectinib. So the Larotrectinib is for adult and pediatric patients with solid tumors with an NTRK gene fusion without a known acquired resistance mutation, for either metastatic or not candidates for surgical resection. In fact, in NCCN, it is recommended as a first-line treatment. Similarly, Entrectinib is very similar, and it is also for the same population. It's also effective against another pathway that you discussed earlier, the ROS1 positive metastatic patients. These two drugs were approved without the necessity for the type of tumor. So pretty much the tumor can come from anywhere. It could be from lung, it could be from salivary gland, it could be from thyroid. As long as the fusion is present, these drugs are approved. So it's called a tumor agnostic approval. So this we are seeing more and more of this, and this is really an important move, an important development in approval of drugs today. Next slide, please. So the Larotrectinib was evaluated in multiple studies, and this is the result of a pooled analysis from 3 phase 1 and phase 2 clinical trials. So there were 153. It's a very rare tumor, and you can it's hard to accrue. So 153 patients. The objective response was 79%, very impressive. Many of these patients had received other treatments as well. There were complete responses, meaning there was no tumor detected on subsequent scans. Partial response was 63%. Another 12% of the patients had stable disease without any progression. Only 6% of the patients had progressive disease identified. So very, very effective drug. Next slide, please. And this shows what is called, this is called a waterfall plot. Anything below the x-axis suggests that there was a decrease in the measured tumor. Anything below the 30% mark is considered as a partial response. Anything that hits 100% is a complete response. So the curves, the graph is very indicative of what the responses look like. Everything is below the x-axis. Next slide, please. These are curves that represent, if you take the 108 patients in the beginning, and there are patients that are lost either, because they didn't survive or they were lost for other reasons. And then at the end, at 42 months, 50% of the patients are still had a continued response. The same thing with the progression-free survival in the bottom. Next slide, please. So these are the studies that are ongoing. This is not even a current slide. Whenever there is a situation like this, it's always important, I think extremely important, to look at the clinical trials that are actively accruing. There are trials that are accruing for patients who, for first line, meaning not treated with any treatment, or patients who have been on prior treatments with Larotrectinib or Entrectinib and have either not responded to it or have progressed after receiving it. Next slide, please. So this is the Entrectinib, similar study, the phase 1-2 pooled analysis. The response here was 57%. There were patients with CNS disease, meaning a tumor that had gone to the brain or the lining around the brain. And even in those patients, the response was 50%. It was very similar in patients with or without CNS disease. There were complete responses, partial responses, stable disease, and again, progressive disease was only seen in 7% of the patients. Median duration of response is the amount of time that the patients were on treatment without having, maintained the response. They had a response and they maintained a response for the duration of time. It was 10.4 months. As you can see, the range was very variable, 7.1 on the lower bound, and it was not achieved. It was not evaluated at the upper bound. So a lot of patients continue to have response after a long time. Progression-free survival is without progression. So it is a little different than the duration of response, and that was 11.2 months. Next slide, please. This is again the waterfall plot on the top, and the second one is what is called the swimmer's plot, and the last graph is what is the duration of response. So all of these are very impressive. The swimmer's plot is tracking individual patients and seeing how long they're on treatment, and if they're continuing on treatment beyond, and or if they stop treatment for whatever reason. So these are all different graphical representations of the efficacy of the treatment. Next slide, please. So this is again the progression-free survival and the overall survival. As you can see, the graphs, it may not seem extremely attractive, but you can see that with this difficult to treat population, there was no progression at 18 months for several patients, and then the overall survival lasted beyond 2 years for 50% or something of patients. Next slide, please. So unfortunately, every story like this has to have a second leg to it. There are mutations, there are resistance pathways that develop to most of these type of targeted treatments. So the resistance can be on target, meaning now we are trying to block. So the Larotrectinib and the Entrectinib block the pathways by just fitting into the socket. The socket itself may undergo a change, meaning there's a mutation that happens, and I've listed all the several mutations that have been noted, and that creates a poor binding. The drugs don't bind anymore, and they're no longer effective. So we had to kind of come up with a different strategy. Or it could be off target. So again, you block at the top, the bottom molecules in the pathway may get activated. So sometimes, either changing the drug, there are some newer generation drugs that are being developed, or sometimes you can combine the entrectinib, larotrectinib with another drug, blocking the downstream pathways. So there are several things that are going on, and again, clinical trials here are extremely important. Next slide, please. So again, in a nutshell, so NTRK gene fusions are oncogenic drivers, but not all NTRK gene alterations are drivers. It's important to know. It's variable frequency in different cancers. Pediatric cancers have higher frequency than adult cancers, and some of the cancers have much more higher frequency than others. Lung cancer belongs to one of those that has the lowest frequencies. All solid tumors, especially those without another oncogenic driver, should be screened. It's extremely important to do that. The next generation sequencing is the most efficient, RNA-based, perhaps more sensitive than the DNA-based. Currently, we have 2 approved agents. There are multiple ongoing studies. There are resistance pathways, but there's a take 2 on this. There are newer drugs on the horizon with very promising data. With that, I will end, and thank you so much.